Good morning, good afternoon, good evening, wherever you are, to you all participating this webinar. It's our second webinar that is organized by the International Standards Committee of Asia. And it's, of course, since we are the International Standards Committee, it's about INSCI, the International Standards for Neurological Classification of Spinal Cord Injury. And you see here on the picture a sub group of this committee, and it's really, I would love to have presented you the picture of the committee today, but the problem actually is, since we have no in-person meetings, it's really complicated to have a picture of all the members of our committee. So our committee, actually, we are 16 people, and it's my pleasure, Rüdiger Rupp, my name, it's my pleasure to serve as the chair of this committee. And today it's really a pleasure for me that Mary Schmidt-Reed and Stephen Burns are doing this webinar together with me. And here are our disclosures. Of course, we are all three representatives of the Asia International Standards Committee. Stephen and Mary are members of the Education Committee, and Mary also of the Clinical Trial Training Committee. And I have some involvements in the European multi-center study about spinal cord injuries, because I'm one of the co-organizers of the INSCI instructional courses within this network, also one of the programmers of the INSCI calculator. So for today, in January, we had this webinar on challenging cases, and we asked you to send us challenging cases, and then we selected those which we thought would be most interesting to you. And today we thought, well, we should maybe then do another approach. And then we thought within the committee that we define actually difficult cases. And we discussed it in the committee, and then we came up with the conclusion, no, we should ask you once more, because you are the ones actually that should have the chance to ask us the questions that you were ever interested in. So what you ever wanted to know about INSCI, now it's the time to do that. And we sent that call on the 27th of May. And the call ended on June 14th, and we received 16 questions on very different topics, and it was really interesting to see which are the main challenges actually that you perceive within INSCI. And we received, here's a list, questions about clinical syndromes, on classification in the presence of spasticity, about voluntary anal contraction. Should there be additional instrumented measures there? Non-SEI conditions seems to be really a relevant topic. And since we have introduced the non-SEI taxonomy in 2019, I think it was worth to do it, because it seems that many questions are related to those. Or the duration of examination, non-traumatic SEI, INSCI non-traumatic SEI, really also a hot topic. NLI, incomplete injuries, multiple injuries, polytrauma, questions on sharp dull discrimination and classification in lumbar spinal cord injury, which we as a committee thought is not super complicated and is not, well, maybe we should not share this with you as an audience. All of those questions, after the deadline of the 14th, we discussed all these questions within the committee, and the answers that we present today are based on a consensus that we reached within the committee. And I really want to make this clear that this is not our individual opinion, in particular because each of us is presenting one case or different cases then, but the answers are really then based on a consensus within the committee. And represent actually the opinion then of the whole committee, and not of our and not our individuals' opinions. So what we have done, and so how we plan this to do today, we have numbered the questions. So please feel free to write questions in the chat. We will all look then during this webinar then into the chat and on your questions that you asked us. And please do us a favor and start your questions with the number of the case that we are presenting, because this helps us then to assign your question to the concrete case. We will then discuss that in the end after we have gone through these 11 cases from these 16, which we thought it's worth to present them to you. And I hope that we will have time then in the end to discuss this with you. For those of you who send in the cases, please be patient. You will receive an email from a member of the committee, so your questions will be definitely answered. So let me start with the first question that we received. And the first question was about clinical syndromes, classification in the presence of clinical syndromes. And the question was, if patients have specific syndrome, for example, which means central cord syndrome or Corder-Equina syndrome, is the ASIA impairment scale still applicable? For example, case with Corder-Equina syndrome who has no motor or sensory preservation at S4-5, will she be classified as AISA? And the simple answers to these two questions, well, the simple answer is yes. Of course, there's an explanation for that. The AIS actually is defined in all cases where a single level of injury can be defined and all dermatomes or myotomes can be tested. So in this case, where you have a central cord syndrome or a Corder-Equina syndrome, and there is no sparing of sensory or motor function in the lowest sacral segments, this individual would be graded as AISA. Although the injury might, in Corder-Equina lesions, might look as an incomplete lesion. Nevertheless, AIS is still applicable, and in this case, it's an AISA lesion. So although the clinical syndromes are still part of the current INSCI edition, however, we renamed actually the chapter, we called it now Patterns of Incomplete Injuries, and do not call it clinical syndromes anymore. Actually, those patterns of incomplete injuries are not based on quantitative criteria derived from motor and sensory scores. And so they can only be, of course, qualitative descriptions then of the pattern of the lesion. And so you feel free to give this information as an option information in the comments box. But the AIS is the way to go in terms of classification of a patient. To our next case, which I think is a case that Mary will then explain to you. Thank you, Mary, for taking over this case.
Thanks. I just needed to remember to unmute. So thank you, everybody, for joining us. It's always a pleasure, and believe me, it's a privilege to work on this committee. So question number 2 presented to us, and it's written as it was presented. If we're faced with a patient with spasticity or spasms that confuse at the time of the assessment of muscle strength, even supposing that it is increased as that value would be scored, would it be not assessable? So the concept here is that we know that in the INSCI exam that we are trying to test for voluntary motion, voluntary and not involuntary. And we all know that spasticity, spasms, tonal, abnormal tone, whatever that, are certainly what we would consider abnormal in this case. And so what we want to do is, of course, you would try, as an assessor, you would try to do whatever you could to decrease those tonal influences or that spasticity influence, be it some people choose to range the limb, some people choose to maybe flex at the knee for a lower extremity to break up the synergistic tonal influence. Some people might rotate the limb or be in a different position. Whatever it is that you can do to decrease those tonal influences so that you can be sure that what you are scoring is a voluntary, single joint, voluntary, reproducible, voluntary motor activity. Okay, so that's what we're trying to do there. If, however, as it says here, if the voluntary muscle strength cannot be reliably determined because you can't reduce that spasticity with all of the clinical techniques that you've used, okay, then you must grade it as an NT. And that's very clear in the standards that an NT can be used for spasticity that is of such influence that you can't reliably say that there is voluntary motion underneath of it all. The big question comes, as in everything else now after the 2019 version, as to whether you put a star on it or not. And this is a great, great question because we are so caught up in trying to determine when to use the star or not. But it's very clear that we're using the star for non-SCI taxonomy issues. And if you think about it, spasticity in these cases are pretty much the result of the spinal cord injury, the release of those tonal influences. And since they are a result of the spinal cord injury, they would not be starred. The spasticity influence would not be starred. So it would, as a great example of an NT that is not starred? We've been asked many, many times, give us an example of an NT that isn't starred. Well, this is one of those examples. Okay, Ruth, I think Stephen is next. Stephen Burns for question 3.
Okay. And this is a great one. It's got some good related points. So if we have doubts about a voluntary anal contraction, if it is weak, if we cannot feel well, is it prudent to request a rectal manometry to remove the doubt? So we are supposed to be able to do this clinical exam with just 2 pieces of equipment, the cotton wisp or cotton swab and a safety pin and nothing else. Yes, it's crossed my mind on other things. Can I feel a contraction in this person's triceps? I'm not sure. How about if I put a needle EMG in? And I've done that, but it's got to be what we find on our clinical exam is what we're grading. And if it feels like there's weak contraction there, we only grade this as present or absent. So if there's weak contraction, you're pretty sure it's there, then it's a yes. If you're not sure it's there, then it would be a no. So we shouldn't be jumping to other instrumentation because that's not what's specified in the standards. An important point to remember about voluntary anal contraction: don't be fooled by a reflex contraction. Sometimes if a patient can produce a bit of a Valsalva, then there'll be a reflex contraction, and this could make a big deal. You could think that somebody's an AISC if they had voluntary anal contraction, and they're actually an A if that's absent and the only sacral finding there. So no, good thought, but we really want to limit it to just the clinical exam.
Thank you very much, Stephen. Next case seems to be for me. Oh yes, this was a very challenging case, or a very challenging question, and it's about the non-SCI condition. And the question was, how can one determine the sensory level when it is impacted by a non-SCI condition and has an abnormal score? Do we refer to the sensory level of the side that is not affected by a non-SCI condition? What about non-SCI conditions affecting both sides, so left and right? So what we can tell here is, first, since we have put a lot of efforts into this non-SCI taxonomy and to bring up a taxonomy where those cases are can be consistently documented, the first thing is document the real examination scores on the worksheet. So if they are, regardless if they are affected or assumed to be affected by the spinal cord injury and the non-SCI condition. In any case, the real examination scores are documented. So normally at the level of the injury, actually, no assumptions can be made on the impact of the non-SCI condition. So the impairment that you see in the sensory or motor scores, it can be actually then caused by the non-SCI condition or the SCI itself. And this is something unique to cases where the non-SCI condition is at or below the level of the injury. If it is above the level of the injury, there can be assumptions made, and normally you rate those those segments then as normal for classification purposes. In the case where the non-SCI condition, and this was the question here, is present in dermatomes at the level of the injury, the sensory level is typically not determinable, so classified as ND. However, usually there is only a limited number of options for the sensory level existing, and these options should be then noted in the comments box, and this then may end in a comment in the comments box, like the right sensory level is between C4 and T1. However, what we definitely can say is, and there was these questions about the level, so can we defer the sensory level from one side of the body to the other side of the body? And the INSCI does not foresee any rule in which levels or scores are transferred from one side to the other. Please remember, there is, of course, this some sort of transfer rule, but this is the motor follow sensory rule for not clinically testable myotomes, but that applies really only to one side of the body. So there is not any rule where sensory or motor scores or levels are transferred from one side from one side of the body to the other. This question was really complicated, and we thought, and the person who sent in these questions actually provided us with an example, with a hypothetical case, and I would like to go into a little bit more details about this case, and I would like to present you the worksheet with some scores that this person sent in. So the case that this person was discussing was a patient with a traumatic cervical spinal cord injury at the level around C6. So at least the imaging of this patient shows that there must be well, the lesion around the level of C6. However, on the left side, there is a concomitant brachial plexus lesion, so superimposed to the SCI. And this is quite a complex case because we have the non-SCI condition here superimposed to the injury, which is in the same range of segments in the cervical level, mid-cervical levels. So the plexus lesion actually has been confirmed by EMG and ENG measurements. And so the question, of course, then now is how to document this case then really correctly, and how to document the non-SCI condition in this case. So the first thing, and that's why we introduced actually the star symbol. The first thing is you document the real examination scores. And please look at the left side. So there are zeros in the sensory and motor scores, so absent sensory and motor function in the level of in the elbow flexors and wrist extensors and the C5 and C6 dermatomes. There are some sort of sensory function and motor function preserved in the lower cervical segments, but you document the real examination scores. However, to indicate that those scores are affected by a non-SCI condition, you tag them with the star in order to indicate that there is a non-SCI condition present. And in this case, because the person did not provide us with more details on this, so we don't actually know the extent of the brachial plexus lesion. In this case, actually, all the sensory scores of the upper extremities and all the sensory and all the motor scores of the key muscles of the upper extremities are then tagged, because we have no more information or detailed information where actually which parts and which dermatomes and which key muscles are specifically impacted then by the non-SCI condition, and that's the reason why we take all of them. So the question then is how to correctly classify the levels in this case, which are then the sensory level and the motor level on the left side, and of course the neurological level of injury. Let's start with the sensory level. So what we do actually is that the difficulty here that arises is that, of course, we cannot actually then distinguish which part of the impairment is caused by the SCI, which is also here in the cervical level, or the brachial plexus lesion. And so what we do actually is we assume that the impact of the non-SCI condition on these star tag scores at level cannot be judged. We have no idea actually. So the scores can be the scores that have been examined. However, they can also be scores present up to normal scores. So the approach here is do the classification with all the scores that are equal or greater to the examined scores, including intact scores, because it could happen that that all the impairment is caused by the non-SCI condition, and that the impairment that is caused by the SCI actually is not present, at least in the segments of C4 or C6. So if we do the classification, and we have a 0 here in C5 for the sensory scores, if we do the classification with the examined scores and all scores greater, including intact, and if we do the classification with a 0, so an absent sensory function or an altered sensory function at 1, this would result in a sensory level of C4. However, if we do the classification with a normal sensory score in the segments of C5, this would end in a sensory level of C5. Means that the sensory level actually in this case cannot be uniquely determined, which means that the sensory level on this side is not determinable. And this also applies for the segments that are below or more rostral and more caudal to C5 segments, also C6, C7, C8, and T1, which could also actually be the sensory level in this case, if the scores are assumed to be normal. So the sensory level correctly, in this case, is classified as not determinable. The question, of course, is then, must this classification be tagged, star tagged? Is it based on clinical assumptions? And if it is based on clinical assumption, then it needs to be tagged in order to indicate that it is based on clinical assumptions. So the general approach here is reclassified with the examined scores. The examined scores are documented. These are zeros here in C5. And if we do the classification based on the examined scores, we come up with a sensory level of C4. And the C4 actually is not the same as when we're taking the clinical assumptions into account, which is then ND. So this means that the ND has to be starred. So the final sensory level in this case is ND star, because it is based on clinical assumptions. If we don't include the clinical assumptions, the sensory level would be C4. Motor level, exactly the same. Also there are zeros in absent motor function in C5. And so also here, the same question, which part is caused of the impairment is caused by the SEI or the brachial plexus injury, and we actually do not know. Same approach, we do the classification with all scores greater or equal to the examined scores, including the normal scores, because the function could also be normal. And there is some sort of a speciality, because we are acting here at transition segments between C4 and C5. And in those transition segments, if the sensory function is normal in C4, and this is the case here, then also the motor function is assumed to be normal. And if we do the classification with 0, 1, and 2, we end up with a motor level of C4. And if we do the classification with a motor score of 3, 4, or 5, then we end up with a motor level of C5, which means the motor level actually also in this case is not uniquely determinable. It could be C4 or C5, and consequently then we classify this as ND, not determinable, and consequently we have to do that also for the other segments, so C6, C7, C8, T1, all the star tagged segments. And actually if we do that, then we might come up, so there is a range of motor levels actually in this case between C4 and T1. So this could, taken the non-SEI condition here into account, we might end up with a sensory with motor levels between C4 and T1. Does it need to be tagged? Yes, it needs to be tagged. Same approach, but like with the sensory level, reclassify with the examined scores, which would in this case end in a motor level of C4, because there is a 0 in C5. And this is, of course, then different to the not determinable classification, and therefore the ND needs to be starred. So in the end, complicated case, in the end, the classification here is ND star for the left sensory and motor levels, and also the neurological level of injury. ND star in a classification, in the communication with others, with other professionals, and in particular also with patients, I think is not really very convincing. So meaning, since we know actually the range where the sensory level and the motor level can be in, it's a good practice, I would say, to provide in the comments box an additional information that the sensory level and the motor level are located between C4 and T1, and the NLI is located between C4 and C6. And the reason why it is C6 in the NLI is, if you look on the right side, actually, then the motor level, and this is also the sensory level, then in this case is C6, so the NLI can only be between C4 and C6. My main message here is non-SEI conditions present at the level of the injury. It's really hard to classify those cases, but they typically result in such constellations where you have not determinable levels. However, you can give information about the range of levels, which I think is quite helpful, and this should be documented in the comments box. Next case is for Mary.
Wow, I get to follow that one.
That's the long one.
That's
the long one, right?
Meanwhile, while everybody's still spinning from that one, and I'm going to put a question in the chat box on that one for you, because I think that one has other implications too. No, go back to 5. Go back to 5 for me. Okay, let's try to do a simpler concept here, but still looking at sensory examination. This was a very interesting question. I think there's really kind of 2 parts to it. Question, we have found out that we do the sensory examination in different ways. And I'm sure that happens in many institutions. And I can tell you that it certainly happens across institutions. We see it in clinical trial trainings, in which order should the examination be done? That is not an uncommon question that we get. Everybody wants to know, is there a standardized order that they should do it in? They also asked, should light touch be done first in all sensory points and then the sharp dull examination, question mark? Or, and this is the secondary part, or is it possible to do one sensory point at a time, one dermatome at a time, switching between light touch and sharp dull before you go to the next dermatome or next point? So I want to separate those two things, all right? Basically, the standards do not dictate in which order that you should do the sensory exam. In other words, if you want to choose to do all of light touch first and then do all of pinprick, or you can choose to do all of pinprick and then do all of light touch. However, it is recommended that you do not switch between the light touch and the sharp dull within the same dermatome at the same time. The reason for that, I think, is really pretty simple. It's that, you know, one of the things that we're dependent upon when we do the sensory exam is being clear and concise with the patient or subject or individual with what we want them to give us back, because sensation is their perception, right? It's not about what we feel. It's about what they tell us they're feeling. And therefore, we need them to understand our directions, and we need to be clear and simple about that. So we're not only in the last sentence there where it says, is it possible to do one dermatome at a time, switching between light touch and sharp and dull? I think you can see in the red here that we're saying not only would that take longer, which none of us want to be longer with this exam, do we? But also it tends to confuse the patient with what they're feeling. And if they're confused with what they're feeling, then they're going to be confused with their answer to you. And so the thought would be to keep it as simple, as clean as possible. Therefore, choosing light touch or pinprick. Complete that and then go to the other modality. However, we wanted to highlight for you here also this article, which was written by Dr. Kirschblum and his colleagues at Kessler in North Jersey. Dr. Kessler, listen to me. Dr. Kirschblum is, of course, part of the Standards Committee, but this was an interesting article that they brought out in 2019, where they actually asked the patients about it and about their preference for light touch or pinprick first, which was interesting to me because I always thought, why would I choose a pinprick over a light touch first? However, they actually came up with some conclusive findings, and basically they are saying that in their conclusion that the patient's reactions and preferences to the sensory portion of the INSCI exam, they found that first-time examinees or patients or subjects, right? And those who didn't recall having one previously, so they're basically acting like they've never had it before, were more sensitive to pain and discomfort from sharp and dull with pin testing than they were to light touch testing. I don't think that's any surprise to us. And so the thought was in the conclusion also that by utilizing light touch first, that you can have the patient more comfortable, calmer, and therefore better able to participate in the exam itself. And they actually questioned at the end of their article whether standardizing the INSCI to test light touch prior to pinprick might be considered. I will say that the committee has not addressed that issue yet to say that it should be. So we're still saying, as it says in the red here, that you could choose to do either one or the other first, but let's talk about what would be preferable if somebody were pinpricking ourselves, right? So decrease the confusion to the patient, stick to one modality and then the other in whatever order you happen to do it right now. I think that's it, Ruud. Okay, we're going to Stephen again.
Right.
Okay. Pretty straightforward question here. The test can be quite tiring to the patient, and we sometimes need to take a break and make a new start the next day. Is there any time limit for the examination of one test? So not absolutely, but it's strongly recommended that you get the exam completed on a single day whenever possible. We know there's some day-to-day variation. That's one factor. Another thing if it's someone with a very recent injury who's having significant neurologic recovery, they may be neurologically very different the next day with some improvement in motor or sensory. So that has to be considered in the decision as well. So shoot for getting it done all in one day, if at all possible. And some ways you could do that would be, on a patient you think may have trouble because of fatigue, start early in the day. Patient may be less fatigued at that point. Gives you the option to come back to it later in the day for completing part of it if you give the patient a break. And if the patient just is wiped out, if it's not time sensitive, the patient's going to be available the following day or the next day, and it's not information that's needed right away. Wait until the next day or another day when fatigue is not a limiting factor. So if at all possible, try to get it done on a single day. Next.
Thanks, Stephen. Oh yeah, still yours.
Okay, me again. So use in non-traumatic SCI, and this question comes up a lot. So our SCI population average age has steadily been creeping up. We often have 70 to 85-year-old patients. Their cause of injury is most often a spinal stenosis that were not detected or treated early enough. Many have comorbidities, i.e. diabetes, rheumatoid arthritis, myelopathy, etc. As ASIA, INSCI, is the best instrument to assess neurology. We use it despite the injury not being traumatic. What is your stance on using ASIA, INSCI, for this patient category method of injury? So there is nothing wrong with using the INSCI for non-traumatic conditions, and it is intended to be used for that. The fact that it was developed and the refinements and the changes were done by individuals working, in part at SCI model systems that see a high volume of traumatic injuries, that is definitely true. But there was never an intention that you would not be able to apply this to non-traumatics. Now, keep in mind some of the decisions made in developing the INSCI. What should the definition of complete versus incomplete be when we changed to sacral sparing in the early 90s, or how many levels below the motor level with motor sparing to be motor complete versus incomplete, more than 3 levels below. That was derived essentially entirely on traumatic populations. And what we know now about the prognostic value of the INSCI, certain things on exam, certain classifications, for the most part has been studied only in traumatic populations. So you should be hesitant to make a prognosis about somebody who has a spinal cord infarction, because I know that this is what's written about prognosis from early exam. It may be true, but it may not be true at all. But as far as a classification, go for it. It's possible. Non-traumatics are more likely to be motor incomplete exams on average, and we classify plenty of AISD traumatic injuries. So use it. And there could be limiting factors like diabetes, secondary conditions. We now have this wonderful taxonomy for classifying and accounting for that.
Thanks, Stephen. I think that's really an important question because we received it quite often also then between the webinars and everything. So this question is asked quite often. The only statement that I want to make here is that it is not intended for stroke survivors. So it still needs to be a spinal lesion. It's also not for MS. So it needs to be a spinal lesion, and whatever origin it is, there we can use INSCI. But not in non-SCI, not in the non-SCI population. Although of course the motor testing and the sensory testing can be done, that's for sure. But the classification, of course, then is really not valid at all.
Exactly. Don't apply a classification to it if it's not an SCI condition. But it's a wonderful collection of the dermatomes and a good place to test them, and a nice sampling of muscles for myotomes as well as a range of peripheral nerves as well.
Right.
Just don't classify it if it's not SCI.
Exactly.
Or dysfunction.
One of the other, and this is for me, but one of the other thoughts in relation to that last question too was that helps me is to remember that the INSCI exam and the classification represents that moment in time. So it is not that it carries through for the rest of the person's life or whatever, but it's what they look like at that moment in time. Okay, on to question 8. This is about the neurologic level of injury in incomplete injuries. And as it says, majority of our patients have incomplete injuries with high, this is takeoff of the previous question too. A lot have high cervical lesions. This complicates setting an NLI or neurologic level of injury, especially if they're very incomplete and there's no specific lesion area. And the example was the same spinal stenosis patients from before. The motor level, light touch, pain levels, presenting with deficits can be 6 different levels. And yes, they can. How would you decide what the correct level will be? Will it always be the highest level, even if that level's light touch level, especially if motor level is even lower than that? So I think the basis of this question or the basis of this answer is really very simply put, that the classification is always, the classification algorithm that we use is always based on the examined scores, which definitely might result in the 6 different levels, 4 different levels, whatever they are. You need to not read too much into that, but if you're going to follow the classification definitions, you simply use the levels that you have determined by doing your proper, concise, and accurate examination. And if that's what it presents, that's what it presents. Okay. In that case, if you look at the bottom red there, we're really going by the clear definition of NLI, which is written in the international standards, which is that it refers to the most caudal segment with normal sensory and anti-gravity motor function on both sides of the body. That is the definition. And so therefore, if whatever is the highest level is what we would call the NLI. And in this particular case, it happens to be a sensory level, the light touch level, then so be it. That is what the single NLI would be at that time. I don't think there's anything else to say about that one.
Thanks, Mary.
All right,
Oh,
then
the next one's still for you. Still for
yeah,
you.
gee, how fun.
Oh,
okay.
Wow.
Question number 9. This is about multiple injuries, and we do get questions about that. Multi-level lesions are usually the questions that we get. However, this one is about concomitant injuries. And so as it says, every few years we get patients with SCI due to spinal infarcts that happen post-heart surgery. I found this interesting. They often present on the T6 level, and I'm not sure whether they meant that motor, sensory, or both, but the sensory fallout is sometimes higher. And I think we assumed that fallout meant that it was not normal, okay? And so maybe they had a T6 sensory level and below that was abnormal. Especially if a sternotomy was done. And so what we have is a secondary non-SCI condition that they feel is impacting here. With sensory fallout without a sternotomy higher than the lesion level, would you deem that as part of the SCI? Should one assume that the sensory fallout with a sternotomy is only due to the sternotomy? I think the first thing that we can say is you don't assume, all right? We cannot assume that. The other things that you can see listed here is our recommendation. In order to get a spinal cord sensory level, we do the best that we can with the dermatones in that surrounding area in order to see if we can get some indication of the neurologic input to those dermatones and not due to the the sternotomy. And so of course we would look across the dermatome as much as we can, you know, as it wraps around the body. However, in order to try to classify the sensory input there from a neurologic basis, from the spinal cord level. If that's not possible at those dermatome levels, then it is going to be an NT. Okay, and we would possibly document, of course, every time we have an NT in a data box, we have to put something in the comment box to say, why is this person an NT? And in that case, it would be an NT star because of the sternotomy being in the way of it is impairing our ability to actually score that dermatome because of the sternotomy in the way. Are we saying that the sensory lapse is there? No, we're saying that it's not testable, but it's due to the sternotomy, so a star. If that not testable dermatome that we just said was an NT star because of a sternotomy was above the level of the lesion, then we know from the way that the non-SCI taxonomy reads that if it's clearly above the level of the lesion, then we would say that it should be considered normal for classification. If it was clearly below the level of the lesion, then we would say that it is not normal for classification. And I think the major concern in here would be if it went back to Rudy's case, which was that it happened at the level of the lesion, and then we would fall back to the responses that he gave you on the at the level of the lesion issues. But we clearly have a sternotomy that is getting in the way of us doing our normal sensory exam. So we have to use our NTs, we have to use our stars, and then we have to look at where the lesion level is versus what dermatomes that we're trying to do, and then go from there. We don't make assumptions across the sternotomy and the neurologic input. I think that's the bottom line of the question, is don't assume from neurologic and a non-SCI condition together. Okay, I think, Rudy, we're back to you.
Thank you very much. Oh yeah, seems to be my case here. So polytrauma. So the question was multitrauma, polytrauma with fractured limbs and surgery of the limbs, sensory fallout. I guess that it means sensory impairment evaluation becomes very difficult to discern between the central and the peripheral injuries. Any advice will be appreciated. So I think this is quite comparable to the case that I presented before, where we had this non-SCI condition, peripheral injuries, then directly at the level of the lesion. And the thing that we can surely say is document the actual sensory function. So document really then the examined scores, so that they are then documented on the sheet, and so that they can be followed over time. And if any change actually occurs, so that these can be then detected. For the indication that there is a non-SCI condition present, we have come up with this non-SCI taxonomy in the 8th revision, so in the 2019 revision, and use the star tag then actually to indicate that there is such a non-SCI condition, such as a peripheral nerve lesion, but you can think of many others. Like swollen limbs or casts or burns or other sort of injuries which inhibit actually then your the examination, or leads to a different examination results, and you use the star to indicate and to tag all those scores that are affected by those non-SCI conditions. This can be above the level of the lesion, and this is the most complicated case, or below the level of the lesion. If the non-SCI condition is superimposed to the SCI, well below the NLI, so if you're really then really caudal then to the NLI, the most conservative assumption is to rate the StarTech scores as not normal for classification, because we assume that there is definitely an impairment caused by the SCI, way below the NLI. Here, your clinical judgment actually is really requested, so that you as SCI experts and know the patient, examine the patient, try the best to isolate the spinal cord function or spinal cord impairment that is caused by the spinal cord injury, and use the tool of the non-SCI taxonomy to provide your expert opinion of what should be used for classification. Meaning, if it is above the level of the lesion, those StarTech scores are normally treated as normal. Imagine a case where you have a thoracic lesion and you have an upper extremity amputation. So though there are, of course, a lot of NTs, you star them, but however, you rate them as normal for classification purposes because they are well above the level of the lesion. If they are typically below the level of the lesion, actually they are, as we said before, the most conservative approach to say they are rated as not normal for classification purposes. But please remember, if you use a star and you indicate that there is a non-SCI condition present, please give the information how do these StarTech scores should be rated during classification. Or at level, and this is really the most complicated case, and there actually both options are possible. It could be normal, could be treated as normal, or could be also treated as not normal. And that was the case that I presented before, where you then rate the scores, the examined scores, and all scores greater than the examined scores, and use those then for the classification. Okay, so I think there is one case left.
This is the last one.
This is, I think that's the last one. It's not
Yeah,
the last
it is.
slide, but it's the last case.
Okay,
Okay.
it's a great question. Someone asked, when testing sharp dull, if the patient feels sharp but doesn't feel dull at all, are you able to score them as a 1, assuming they say it isn't normal, or do they need to be given a 0 since they're not differentiating between sharp and dull? So the committee consensus is that they actually have to be able to feel, perceive, report both, so sharp and a dull, in order to get a score that's better than 0 for the sharp dull discrimination. And we thought through this. If it's one of these ones where you're not sure and you're having to test somebody 10 times and making sure that they get it correct at least 8 out of 10 times, if we touch them with the dull and they're feeling nothing and can't report that they're feeling anything sharp or dull, we wouldn't want them to just be guessing, I can't feel it, so maybe it's dull. Like, it just doesn't make sense. They've got to be reliably on this. So in their, if we tested them 5 times sharp and 5 times dull, they would get the 5 dulls all wrong, because they wouldn't reliably be able to say when the dull was touching them. So we feel like the best answer is no. They have to be able to perceive when both of those types of touching, the sharp touching and the dull touching, is occurring, in order to give them something other than a 0. Okay.
Thanks, Stephen. So I think these were the 11 cases that we wanted to present to you in this webinar. So please let me conclude. It seems that there are a wide range of topics actually then relevant for you, and where you encounter some difficulties. And I think the responses that we got to our call for questions showed us. The non-SEI condition related questions were most frequent, also not only in the challenging cases webinar of which we gave in January, but also in this seminar here for the Ask the Expert survey. Of course, I think we are still not at the very end, and we have not answered all your questions. And so we intend to continue these kind of webinars for challenging cases, and also send us more general questions. It does not need to be cases, but the questions can be on a more general level. And this was the intention with this webinar, so that we ask or that we respond to questions that were asked on a more general level. What we also plan for the future, and the STAR concept and the non-SEI taxonomy seems to be relatively complicated. Well, it is complicated, and we plan to have maybe an own webinar on this topic, how to classify or how to perform the INSCI classification correctly if there are non-SEI conditions present. However, what I would like to draw your attention to is that there are very recent INSCI publications available, and all of them, I think, well, most of them actually are accessible then as open access publications. The first one is the booklet itself. So the 8th edition of the International Standards for Neurological Cases of Spinal Cord Injury is now available as an open access publication in topics for spinal cord injury and rehabilitation. It has been released, I think, in May 2021, so really recently. And please feel free to download that, and so you can then actually read the standards itself. It's for the first time that this booklet actually is really then available free of charge. And we are currently working on a special issue on INSCI in spinal cord, and there have also been recently 2 publications are available. They are not yet in the print edition, but they are available as online in the online editions. And the first one is related, it's some sort of a reference publication, is related to the taxonomy, for the non-SEI taxonomy, and how to apply that correctly, and the basis, the theoretical basis behind it. And we have also recently, Steve Kirschblum, Mary Schmidt, and myself, we have also published a publication about classification challenges in the 2019 revised INSCI standard, which is mostly also related to non-SAI taxonomy, but also the new definition of the zones of partial preservation. And if you want to know about the consistent classification in the presence of NT, then I would like to draw your attention to a little bit older publication that also one of the committee members and a colleague of mine, Christian Schulz, has published in 2012. So we are at the end of the webinar, and of course, then happy to receive questions, and we still have time to answer questions.
Rudiger,
can we go to? Oh.
Yeah, of those questions, could I take the second one there, the one from Miriam Berry? So that was in relation to the case number 7 or question number 7 about using it for non-traumatic injuries. And this is a great question. Well, what about somebody with multiple sclerosis with the spinal cord only lesion? So it may be appropriate, it may be useful for you to record the exam of such an individual using the INSCI sheet. But you should not apply a classification to that specific situation. So you're saying, well, if it's only spinal cord lesion, well, we would need more than one lesion within the spinal cord, or it wouldn't be multiple sclerosis, right? We need at least 2. So if they had sort of 2 plaques within their spinal cord, and it was, they were meeting criteria for it being MS, well, then that would be in a situation where there are 2 different levels of cord injury, or two things affecting the cord, which is also another case where we don't apply a classification. And so there definitely are individuals with MS who, functionally this person looks like they have, T6 AISB. They've got a big plaque. They have no movement in their lower limbs. So it would be okay to indicate in the notes that they look similar to this, or the spinal cord lesion they have appears to be giving them that pattern, but it would not be appropriate to apply the INSCI to it, because the INSCI has been validated for a pure single spinal cord lesion. You can't apply it in cases where there's multiple going on. And it was a single demyelinating lesion within the spinal cord, transverse myelitis. Go for it. That's a non-traumatic condition. So I think we're splitting hairs sort of a little bit there. But if you if there are multiple spots where the cord is involved, or the typical case where somebody with MS that has brain level disease as well, it's impossible to classify the spinal cord portion of that.
Just to be clear, Stephen, did I hear you say in transverse myelitis you would use it?
So that's it's considered a non-traumatic condition.
Viral.
Single lesion. Fits within the whole taxonomy of non-traumatic conditions. My experience as a VA physician, where we treat traumatic and non-traumatic, about 40% of our patients have non-traumatic conditions. Some chunk of this is people with transverse myelitis, and we've applied it to them.
Yeah. Okay. And the difference is because of the single level lesion, as opposed to MS, which you think is more sporadic. I just wanted to make that clarification. Yeah, because you said the words, but I just want to make sure the audience understood. And Rudiger, I'm going to ask you to go back to the full worksheet on case number 4. And I'm going to go ahead and answer the last question that just came across, which was, for pressure ulcers taking up the full dermatonal testing area, would this also be listed as an NT? And my personal answer to that NT star. And my personal answer to that is yes, it would be, because you're saying that dermatome is not tested, and you're saying it's not testable due to PU, or pressure ulcer, or PI, pressure injury, as the language goes now. And then of course you would go to the comment box and you would say why it is an NT star. And then you would also say how to use it in reference to the classification, normal or abnormal. And I guess we'll assume that it's a buttocks or a sacral, ischial or sacral pressure injury. And if it is, and if it's below the lesion, then you would be calling it as to consider abnormal for classification. So that's a simple answer, I think, on that one. My question for you Rudiger on question number 4.
May I,
want you-
Mary, may I add to this
Oh.
to this question here?
You're the chair. You can do whatever
no,
you
no, come on, Mary, just kidding. So, Ms. Link, so your question is absolutely valid and right. You would classify it as NT star because it is a non-SEI condition. So it's not testable, and you normally then provide the information. How should then this be rated for classification purposes? And I mean, as we know, pressure ulcers or pressure injuries are often present then in the chronic population. If you have an examination result in a chronic patient from a former exam where the pressure injury was not present, you are of course then allowed to say that this score, the sensory score, should be used as, and then you actually you name the or use the sensory score that you have available from your prior exam. Could also be then if you have more specific information about this in a chronic patient, you can also then use this as a for classification purposes. Please look at the non-SEI taxonomy publication, because we have exactly such a case in it's the third case actually then in this publication, and there it is really described in a very detail. So Mary, you had a question to me, I guess, so that's interesting.
I have actually one comment, one question on case number 4 there. I just wanted to make the point of how important ND can be, or not determinable. And I've been dealing with a lot of clinical trials lately, and the issue of when you have those borderline cases that we end up having to use an ND, whether in this case it was for the sensory motor level and NLI, but then there's also cases that we've seen where it's in the AIS and whatever. And of course it's important clinically, but it's also very important in research, because if you don't use the ND in cases that are questionable like that, and you then do give a certain level or a certain AIS or NLI, and then if that person, for whatever reason they were not testable, or something changed that they then became testable, and then you were able to give actual scores and actual assign AIS and whatever, it may look like the person actually changed neurologically when maybe they didn't. Okay, but maybe in the beginning when you should have given an ND because it was not determinable, maybe the underlying stuff was there, you just couldn't use it at that time. And so you want to be sure that your sequential exams are not misleading about change either in a positive or negative direction, simply because you chose to classify it distinctly instead of using an ND with something you couldn't determine. That was the point about NDs. But I want you to go ahead, and because I think there's many questions that come up, even though it didn't in this round, about the ZPPs. And if you could talk to us, forget the right side, that should be pretty obvious, but on the left side in this, if you could go ahead and say why you gave the sensory and motor ZPPs that you did on the left side.
Because so there is function preserved down to maybe I have a.
I think the sensory is obvious, actually. If you look at the sensory columns, you see there's all the way down to T5. So I think the bigger question that I'm anticipating to come, if people really look at this, is why the motor ZPP on the left side, why is it a T1 versus is it a T1 star?
In this case, actually, we have definitely examined a 1 as the examination score in T1. So the assumed scores can only be greater than the 1 that we assessed in this case. And so there is function definitely preserved without clinical assumptions in the T1 segment, and that's the reason why we why independently of any assumption, actually, there is function preserved in T1, and that's the reason why we don't tag it, because it's not based on clinical assumptions. Was this okay?
Mary, are you thinking of some exception where?
I think the gray zone on this one, this is why I wanted to highlight it, because I think the gray zone on this one is the fact, when we talk about the definition of the ZPPs, we talk, and I'll specifically say motor in this case, because this is the one we're questioning, but it's similar concept for sensory, is that we say you start at the defined level and you look at what's preserved below it. Okay. And so if this had a clear motor defined level, then we would say, what's below it. However, in this case, it's a gray zone too, because the motor level here was an ND star.
You're right. And it could be.
So the motor level could have been what? C4, C5, C6, C7, C8, T1, whatever you find in there. But even so, the T1 level has a star to it.
You're right. In this case, it should be starred. And to make it very short, so if you're in doubt actually of starring a classification variable or not, so if you are really in doubt, then star it, because it indicates that there at least might be some assumptions in this classification. And in this case, actually, you're right, because T1 could also be the motor level. You're absolutely right.
However, Rudiger, wouldn't if it truly was, then for the zone of partial preservation, where we are entering the
level, which is a
motor level,
which is a starred level.
Yeah. So
the only possible motor level here that wouldn't be starred. No, that's not even true.
No,
whatever the motor level is on this one, the bottom thing that's available in key muscles is T1 starred.
Yes, but the zone of partial preservation does not change. If the motor level is C5, C6, C7, C8, or T1, the motor ZPP does not change. It always stays at T1. And since it does not change.
It's T1 starred on the form. And so I think for our audience.
A disagreement. We had to have one.
So for our audience, you need to understand that we take these questions seriously, and we do talk about them as a committee, and we do look for consensus. And so I don't think that question that I posed is a simple answer, but obviously between us, we have different opinions.
But I think Rudiger's right. So
T1 is correct.
There you go. I've been outnumbered.
No star.
Because it does not change. It does not change whatever the motor level is.
Because of how
I get that concept. I think though that people will look and say it doesn't change, but it is a starred data point, and that's why they'll put a star for it. So I think that is definitely a confusing factor.
Yes,
and I'm not saying it should be T1 starred. I'm saying it's a confusing one.
I agree with you. It is confusing.
That's why I brought it up, was it was confusing, not because I disagree with you. Okay.
Okay.
Did we want to address the question number one?
I know. I think we need to give that person, because he wrote it very early. We should get
waiting the longest.
Yes.
And it was about a patient who sustained a dual TBI and a spinal cord injury. It's not a spinal cord injury per se, but cord edema at C1, C2. At this time, it's hard to do the full Asia exam or INSCE exam, as he is still confused. What I could get from my attempts motor level of C4, sensory exam unreliable. How would I classify him, and would cord contusion consider SEI? I must admit, from my personal view, this patient is not reliably accessible actually then by the INSCE exam. And since the results, actually the examination results are I would say somehow erratic, I would definitely not classify this person, at least not at this stage. And since there is another, well, it is not only a spinal cord injury, but also a TBI. Even the spinal cord injury, I think, is not for sure. And there is a TBI, which, of course, additional impairments. I'm not sure if the INSCE exam here is the right tool.
Is reliable, right?
To classify, and the reliable tool to classify such a patient. Does not mean that you should not perform a neurological exam on these patients for sure. But
Right.
I'm not sure if an Asia impairment scale actually is appropriate to classify the severity of the spinal cord injury in this case. And I would say, no, it is not.
I agree.
And I totally agree. And I think there's a couple questions there. And the main issue was his TBI and his confusion.
Right.
But the other issue, the other question that the person posed was, would the cord contusion be considered an SCI?
Mhm.
And I think everything that I know of it is, because it's impacting the cord. If it impacts the cord, and you're even saying they're incontinent of bowel and bladder and
Right.
whatever else, then I don't see why it would not be.
Yeah,
That's
I-
true. That's
Okay.
true.
That's
I
all
mean,
the questions we had.
that's true.
So we either totally confused everybody or we totally
Could be.
clarified everything, right? But we appreciate the questions.
Good question.
Absolutely.
Keeps us on our toes.
So Mary and Stephen, I thank you so much for being part of this wonderful webinar here, which we do regularly. Maybe then in another, I don't know, in another with other members from the committee. So we are not the only ones. And I would like really to thank all the participants of this webinar and also for asking questions. So please feel free, as I said, send in questions to the Asia office. Some are directly answered then by the Asia office. Some actually are then forwarded to the committee. And we are happy to receive those questions because this shows us actually, this is the feedback that we need from you. In order to understand your needs and your maybe then your problems and challenges that you have with INSPI. And so for us, it's valuable information that we need in order to enhance our and foster our discussions within the committee. Thank you so much to all of you. Stay healthy and lucky and happy, of course, and hope to see you then in the next in our next webinar. Thank you so much.